Okay, yeah. Good evening, good afternoon, good morning, everyone. Once again, thanks for attending our sessions. Special thanks to Dr. Mankad, Dr. Mursky, and Dr. Bolthauser for joining us as expert panelists. We have a total of 10 cases and one follow-up case. So we'll start off with the first case. Geeta, if you're there, you can present the case.
Yes, sir. This child was a 10-year-old male child who presented with a fever for 2 days and a headache. It was bifrontal, and throbbing type of the headache. And on day 3 of illness, he had a seizure. It was a generalized tonic seizures, and later on, started to have involuntary movements, altered sensorium by day 4. And the seizure semiology was like just the staring ones. And day 5, he had a seizure for which we have given a lorazepam, and just within a weight appropriate dose, he had a sudden collapse and he has to be intubated. And post intubation next day, he had progressive coriform movements and poor breathing efforts were there. During these we were wanted to differentiate epileptic versus non-epileptic, and during these episodes EEG was done. It was normal. So he was requiring ventilatory support for almost 4 days because of the poor breathing efforts, and the spontaneous efforts were also not that much. So later on, it has improved. So post extubation, he had imbalance, truncal ataxia, behavioral issues, dysarthria, and these all gradually are recovering. He's discharged now, but all these almost persisted for almost 2 weeks.
Okay. So the first scan is after the intubation or before the intubation?
After the intubations.
Okay, all right. You have two sets of scans 1 week apart. This is the first scan. On top, you have the T2 axials, possibly some edematous changes in the cortex or in the frontal lobes. Coming down to the striatum, the dorsal striatum are edematous, demonstrating confluent T2 hyperintensities. Thalami appear to be relatively spared, no central white matter abnormalities. Brainstem, no signal changes. Cerebellum also, I cannot appreciate any signal abnormalities or volume changes. Diffusion, again, slightly hyperintense foci, hyperintensity on the dorsal striatum, but again, no other changes. The flares of the striatum again demonstrate this swollen appearance. ADC does not revert. SWI could not appreciate any foci of blooming, and on contrast, the frontal regions were normal, and also the dorsal striatal cannot appreciate any significant contrast enhancement. So this is 7 days later. Geeta, what was the medication between the two scans?
First, we have treated him in the lines of encephalitic illness because we have a CSF with cell count of 700, sir. And we have investigated accordingly with the viral PCR and also, but it was negative. Other infective etiology for JE we have investigated for the demyelinating and also autoimmune disorders. Everything came out to be negative.
No, this was after the second scan or before the first second scan? The workup.
The workup was before the second scan itself.
Okay. So yeah, 7 days later, you can appreciate that there is some progressive volume loss in the cerebral, predominantly in the cerebral hemispheres. The edematous change in the dorsal striatum are slightly reduced in comparison to the index scan. No abnormalities in the brainstem or cerebellum. No signal changes on the diffusion weighted sequences. The upper cervical cord demonstrates normal appearance. On the flares, again, you can appreciate the reduction in the swollen appearance of the dorsal striatum, possible hyperintensities along the centromedian and pulmonothalamic nuclei. The medial temporal lobes also appear, amygdala appears slightly hyperintense. Post contrast, there is no enhancement. So based on the imaging findings, we thought of possibilities of viral infection, as Geeta has stated out. Also, mycoplasma was one of the considerations. Autoimmune, again, the autoimmune etiology is involving the striatum, that is NMDA, D2, and CV2. I think the case is less likely for an inborn endometabolism, but these are the differentials for the dorsal striatal abnormalities.
And one more
Yeah.
history is like last year also he had similar illness, but he was like only 3 days with severe headache and mild encephalopathy, but he was discharged within 3 days, and that time scan was normal. We don't have a scan, but in the summaries and all, it's normal. So.
Okay, so this is the workup. Again, dengue mycoplasma was negative, NMDR negative, MOG was negative, and
JE
I
is
think
also
Jap
negative.
is negative. So I'll open the case for the panelists to discuss.
I think that white cell of 700 odd is very strong in favor of a primary infective process. And I wondered whether the process was quite generalized even on the initial scan. The cerebellum is questionable as well. I think it becomes a little patchy on the follow-up as well. But the CSF breakdown would be relevant as well in terms of types of cells.
Geeta?
Yes.
The types of cells is lymphocytic predominance, and
It was lymphocytic predominance.
all those things have to mention, no? Protein, sugar.
Was the protein raised?
Protein was around 70. So.
Sugars were normal. Sugars were
Sugars were
74.
normal.
Proteins were 76. And cell count, almost 90% lymphocytic dominance was there. So it looked very viral infection kind of thing, but with the kind of abnormalities on the scan, so dengue, JE are the possibilities which can give rise to, but that degree of pleocytosis with dengue is also very unusual. Even JE also does not give so much of pleocytosis most of the times. So in spite of in 2022 as well, with all the armamentarium what we have, we still get an undiagnosed encephalitic illness. And he took a reasonably long time to get on his feet, but currently at least he's walking with support.
So I've had 2 cases in the last 6 months with similar MRI changes. And the first one, pediatric colleague had already done EBV, VC, IgM in the blood, which was strongly positive. So the second one also I did it, and it was strongly positive again. So I'm not sure if EBV causes a similar, this process, which sometimes we don't check for EBV.
PCR panel you have displayed, Geeta?
Yes,
CSF,
PCR
it's not
panel we haven't displayed, sir, but it is more.
No, PCR, CSF, EBV is not sensitive. So it will be more in the blood. Antibodies, you must have been a CSF PCR, right?
Yes,
Yeah,
sir.
CSF PCR. Yeah.
That won't be I don't know if it covers EBV, and but in
Yeah, it
EBV
covers.
it's more the blood. PCR is so insensitive, except for HSV, for that part. IgM, VC IgM might be a useful test.
Okay.
Any liver abnormalities, Dr. Lokesh? Someone in the chat?
No,
Dr.
no,
Sunil
no.
asked.
Yeah, not there. Yeah.
At least the imaging picture does not typically represent a ANEC. I think one of the comments was a possibility of ANEC because of the recurrence.
And then TPO antibodies. Did we do TPO? Even though it's not a specific autoimmune phenomena, but sometimes it helps for this being an autoimmune process. So again, have seen similar lesion with a TPO strongly positive antibody response.
I think the cellular response was something which was driving us towards the infectious process.
But this is a very lymphocytic and high protein. So it is an inflammatory process, not necessarily infectious. Scrub was negative. Did you do scrub?
We haven't done.
Yeah. Scrub, this child scrub was not done. Yeah.
Because
the lefties were normal, and he was treated with doxycycline, I think, in the initial period, but I think I'm not sure.
So in terms of what is common, this is likely a viral encephalitis, and not that rarely you don't find the exact pathogen.
Yeah.
This is not surprising.
Yeah.
Yeah, sure. We at our institution
as already Kish said, 760 cells are not in favor of a demyelinating condition.
Yeah, I agree. And I was just going to chime in and just say that we do next-gen sequencing of the CSF in these type of patients. And even with that, rarely do we get an answer of which bug it is. So it's more common to not know what it is than to actually find the bug.
So the thing is, but it's so surprising. If it's a viral process, there is no diffusion restriction, right? There's no diffusion restriction. So you don't have a cytotoxic process, whatever is an inflammatory process in the brain. So that is more of an autoimmune inflammatory rather than a direct viral invasion. So
there was a recent, can I jump in? There was a recent paper from Finland, almost 100 patients with a clinical diagnosis of encephalitis. And in 40% of these children, the initial MR was normal. So normal MR is still in keeping with a severe form of clinical encephalitis. I'm not surprised if you don't have ADC changes.
I agree.
So MR normal, but you have a lesion which is not restricted. And were those cases microbiologically proven or they were just clinical? Because you can never have a clinical viral encephalitis. They have to have a microbiological diagnosis. That's just an assumption.
They have done what you do today in routine with all kinds of CSF.
But you mentioned they were clinical diagnosis, not microbiological diagnosis. So they were diagnosed as possible viral encephalitis.
Encephalitis is not a microbiological diagnosis.
Yeah,
definitely. Yeah, in the majority.
It could be any inflammatory process will present like encephalitis. So that can be any inflammatory process. What I'm saying is there are two things you mentioned. One was clinical diagnosis of encephalitis, which means many didn't have a bug identified. And second, you said they had a normal MRI, but we're not dealing with a normal MRI here. We're dealing with the MRI which has got basal ganglia changes.
I think, in other words, the question was, if you have signal changes without restricted diffusion, does it favor away from a diagnosis of viral encephalitic process or encephalitic process?
Yeah, exactly.
I mean, I would say experientially for us, the answer would be no, that I don't think it would steer you away from a viral infectious process.
Because generally what we clinicians think about is it's no restricted diffusion, more likely to be demyelinating, or where there is no cytotoxic edema, which is something like a demyelinating or inflammatory process more than the encephalitic process. I think that's the question we are trying to get an answer.
Kish and Nihaal, I'd love to hear your experience, but I mean, I'd say the bulk of our viral encephalitides don't go on to have cytotoxic edema.
Just a quick point, Dr. Lokesh, I wanted to add. I think we did discuss about D2 receptor encephalitis as a possibility here, I think. And I was reviewing the literature, up to 400 cells in CSF are reported, but this was a little too high for whatever was reported in the literature. And then I think there is a paper which suggests about CSF pleocytosis in autoimmune encephalitis, and they have, especially in NMDR receptor encephalitis, they have reported up to 700 cells in one of those papers, with quite significant variation in cell count from 0 until 700. So, I mean, with what Dr. Jain was saying here about no restricted diffusion and thinking about autoimmune process, I mean, it still possibly could have been there, but we haven't proved anything for this boy as positive.
Yeah, DR2, because it is not commercially available. We tried once, once with Fabian and team in Australia. We didn't get an answer, so that's why we didn't actually send it across.
Yeah. So, I mean,
the only thing that is worrying to leave it as a viral encephalitis is the previous episode of this child. I think this is an endless debate whether it is viral or post-viral phenomenon. Frankly, it's a virus triggering it.
Yeah.
And what we're seeing could easily be a para-infectious phenomenon. Now, the NMDR is awaited. I know that.
Negative.
I don't think we can be specific about LGI and DR2s based on imaging. At least we are not there yet. So there has been volume loss between two scans as well. The question is back to the clinicians, at what stage would you be confident to actually add an immunomodulator or steroid sparing agent or even steroids if you were thinking on both grounds? Because I think what matters to the discussion is the outcome for the child eventually, isn't it?
Yeah, if the infectious process, in the sense there is no high grade temperatures and the child is still having symptoms, you're covered with your antibiotics, antivirals. Sometimes we do try immunoglobulins and steroids in this sort of situation as well, explaining the pros and cons.
Lokesh, you
Yeah,
will
that way.
agree. Lokesh,
Yeah.
we always look at the MRI, and if there's no diffusion restriction, we give steroid, right? We tend to
Yeah,
sort
yeah,
of
that's
use
what.
that as
Yeah.
a discriminator, right? So, yeah.
Only
So-
thing for us was the number of cells was actually which was holding us back to do anything in the initial part of the illness. Yeah. I know that's
But
up to the.
predominant lymphocytes and high protein doesn't really take it in one particular direction either, right? Common things being common, we think about virus.
Yeah. Yeah.
But I'm beginning to feel that every virus provokes a para-infectious autoimmune phenomena, which you might not find an antibody for.
Antibody. Yeah.
I think I agree with Dr. Mankar as well as Dr. Linkappa that here in our institution, if the initial virological panel is okay and the patient is having severe impairment, we do tend to treat with steroid and IVIG because nothing is going to be lost.
Cytokine levels, no, actually we don't do cytokine levels regularly. Sometimes we do the interleukin 6 levels, which is easily available to us, not the other cytokines.
And the interleukin 6 was going to be raised here, right? Whether we've done it or not, that's a pretest probability.
Yeah.
But how does that help you?
No, I think there is a question, so I was just trying to answer that.
An interesting thing, which I don't know whether I can prove or I've sort of observed. So where you have a cytokine storm, you tend to have a diffusion restricted brain, like ALRED, acute leukoencephalopathy restricted diffusion, or those phenomena where you think of a very quick cytokine response. While in an autoimmune process, you tend to have non-diffusion restricted lesion. Just something to think of. Yeah. So cytokine storm causes, so the early immune axis response causes more of a diffusion restriction like viral encephalitis, but a later response, para-infectious, causes more of a non-diffusion restricted lesions where steroid should help. Just a thought.
I think we can move on,
Okay.
but there's
Yeah.
one point.
Yeah.
One point I want to make about restricted diffusion. I don't think it's a binary output, whether it's restricted or not. We can have various levels of reduction in ADC values, which the human eye may not always discern. So I think it's not a binary output, whether it's restricted or not. It's a very difficult way to judge that, to decide one pathway or the other. And it depends on the timing of the scan as well.
Yeah, sure.
But
I think
the
that's
question
useful.
is the threshold to give IVIG is what I was actually challenging in the context of any viral infection.
Very variable, Kish. Very variable depending on the institution or the protocols they follow. But I think most of us are more comfortable post-COVID to use it in our armamentarium more easily than earlier. That's for sure.
Let's move to the next case.
Okay, great. Thank you. Thanks, everyone. Next case, Ashwin.
Yeah, I'm here.
Yeah, go ahead.
Yeah. So this is a 2-year, 3-month-old child born of a non-consanguineous marriage and was born by LSCS and was developmentally normal with uneventful birth history, had come with multiple episodes of generalized clonic seizures lasting for about 5 minutes each time, occurred every 10 minutes without regaining consciousness. Child also had status epilepticus earlier at 18 months and 2 years of age, and that was not associated with fever. And even this time, there was no fever associated with the seizures. So this child was admitted in another hospital where the child was being treated as refractory status epilepticus, and then in view of being super refractory, was referred on a IV midazolam infusion, and multiple anti-seizure medications were going on. After being admitted with us, a CT scan was done, which was showing some hypodensities in the gray and white matter, which were bilateral and more generalized.
But in view of that, the child was given IV methylprednisolone and IV cyclosporin. Clinical diagnosis of possibly ALERD was kept, and a child was mechanically ventilated for 6 days and thereafter was extubated. Seizures settled by day 3 of admission, and MRI done on day 7 of illness after extubation is what we have with us now.
Any labs, Ashwin? CSF?
Yeah, so CSF, actually the CSF report we don't have, but the referring doctors had said that it was normal, but we are not very sure whether it was done or not. We couldn't get the history clearly, but since the child was not having fever at all in the history, it was not done at our end either. The only abnormal blood reports were a hemoglobin of 6.6, which required a blood transfusion, and a calcium which was 7.5. Yeah, so a little low calcium, 6.2 calcium and HB of 6.6. These were the abnormal reports. Otherwise, the liver function tests, renal function tests were normal, and total count was 13,500 with a neutrophil count of 78%. So with this, the child's MRI was done only after extubation, and seizures settled by day 3 of admission.
So we have the MR images on top of the diffusion, and you can appreciate diffuse extensive areas of restricted diffusion, primarily involving the cortex and some areas of the subcortical region. Some areas of the thalamus also demonstrating areas of restricted diffusion. Over there, the temporal lobes, frontal lobes, parietal lobes, again, extensive involvement. The posterior fossa structures are relatively spared in terms of the diffusion changes. Possibly at the anterior base ganglia, the caudate also have some areas of restricted diffusion. On the T2 and flare, you can appreciate the corresponding edematous changes, primarily involving the gray matter, the cortex. Posterior fossa, again, no abnormalities. There is some degree, mild volume loss, but not very significant. So based on the presentation, I thought of possibility of postictal etiology. I think status was a previous presentation, so I think we just got confused over there. But yeah, one of the differential thought was postictal etiology causing these areas of cytotoxic injury. The other possibilities which have been ruled out by actually given the labs or Paul-G and hyperammonemia, which can present with these diffuse abnormalities. I think there's no history of hypoxia, so hypoxic injury was again not considered. So based on that, I'll open the case for discussion.
What was the EEG like?
Yeah, EEG was
generalized slowing, I guess.
Generalized slowing, yes. It was showing generalized slowing. Generalized slowing.
This was on midazolam infusion.
Yes, yes. Patient was on midazolam infusion initially, was referred to as on an infusion. And that was continued for the initial 1 day. And thereafter, the child's, we were able to taper it because the seizures reduced by, started reducing by day 2 and completely subsided by day 3.
This is not
do
a
we have
pattern
follow-up
for
imaging?
Sorry, Kish, carry on.
No, we don't have a follow-up imaging of this patient yet.
So clinically, clinically there was a previous episode of status epilepticus, though that did not, that did not leave any residual neurological deficit. So I think there is something underlying, and somebody posted in the Q&A metabolic, and looking at that, I thought, oh my God, whether this is poor. That was the first thought that came to my mind.
Yeah, we were also thinking whether it could be SCN related or whether it is CACNA1 related seizures and super refractory status. The other was initially we did think that it could be even Paul-G as well.
Doesn't look like Paul-G. Every time I've seen this now, it's turned out to be one of the following. Either status epilepticus driven anoxia, which the brain will suffer from. 2, a viral infection driving this entire process. And 3, a hypoxic ischemic episode of some description. but we don't seem to have a strong handle on the hypoxic theory. You can see why this kid would have developed dystonia. They've got deep gray involvement already.
Yes, sir.
I could see a lot of immunomodulation being given. I think that was probably pre-MRI.
Yes, sir.
Yeah.
MRI has been done on day 7. On day 1, that means the child had developed the illness about 3 days before that, and then the child has come to us, and on that day the immunomodulation has been started with methylprednisolone, cyclosporin right away, because the CT scan was showing the generalized hypodensities, and we were able to get an MRI only after extubation, which is after 7 days of immunomodulation.
And that's slightly challenging, isn't it? Hypodensity doesn't mean anything towards your diagnosis, and you have a child with status, either a refractory established status or for known etiology. We have not done a CSF. So I think I'm not sure how aggressively we'll be immunomodulating based on that information as a clinician.
It's a girl, right? They can have this PCDH19 related epilepsy where they can present with just status epilepticus, and in between episodes they can be fine. This is a distinct syndrome which occurs in girls. I mean, I had one child who came with a similar episode, but she's absolutely fine now. So, and minor illnesses can trigger the status epilepticus. And I think recently in AOC and yesterday, they presented a case of PCDH19 along with, I think, fires where they gave immunomodulation. So I don't know.
Dr. Adiga, I think what you are referring to is whether the entire clinical episode for the last 1.5 years, including this MRI, is due to a single underlying genetic issue, or is a genetic issue plus a super refractory status epilepticus that is a modifier on the MRI. So the MRI picture is something related to the underlying etiology plus effect of status epilepticus. So then the differential diagnosis would be very wide. So if it is a CN1 or a PCDH19, I think the MRI is probably related to the status epilepticus. And following status epilepticus, people can develop movement disorders.
I mean, I'll just chime in.
Yeah, right. Sorry.
I know. I was just going to say I concur that. I mean, we see this not infrequently from status epilepticus itself, primary cause, and then obviously it's always hard with status happening. Is the child becoming hypoxemic along the same time, and then are you having two different things working against the child at the same time?
Ashwin, any follow-up details? What's the plan?
The child had dystonia and is well controlled on the anti-seizure medications. We are yet to see the child at follow-up, but on a phone call we learned that the child is seizure-free, and however the child is bedridden and with a lot of dystonia. So we hope to see the child at follow-up in the OPD and perhaps decide then whether we need a follow-up imaging or not.
There's a question on role of cyclosporin in this situation. Mahesh, you are there?
No, sir. He is unable to attend the meeting today, sir.
Okay, sure.
Yeah.
All right. We'll move on to the next case. Yeah, Ashwin or Tanuja? Where is
Yeah, Tanuja.
Yeah.
I'm actually unable to see this. Okay, fine. So here was a 12-year-old girl who came with fever of 5 days and 1 episode of vomiting on the 3rd day of fever. She also had altered sensorium from day 3 of fever in the form of increased letharginess, sleepiness, and altered behavior for 3 days. On day 5 of fever, child developed 2 episodes of GTCS at a referral at another hospital, for which she was intubated and then referred here. So here we did CSF analysis, which showed 74 cells, 94% being lymphocytes, a protein of 44 and glucose of 85. At the time, the RBS was 140. There is a history of child staying in an area which is surrounded by paddy fields and also animals. So there is a history of tick exposure present. She had received 2 days of doxycycline at the other hospital and was afebrile after that. On admission to our hospital, we got an MRI done, which will be shown next. And we gave 5 days of methylpred pulses. Currently, the child is still on HFNC and she's having hypotonia, but there are no abnormal movements. EG was done, which showed diffuse slowing of background, suggestive of encephalopathy.
So MRI was done at which day of illness?
Day 6, sir, after
Okay.
5 days of day 6.
Okay, sure.
Can I ask, the ticks in that area, they carry viruses or Borrelia or both, or you don't know? I mean, the severity of this illness is against neuroborreliosis. This is likely, if anything, a viral tick-borne encephalitis. And this can be very severe, and also the outcome is not always optimal.
Sir, we know that she stays in a residential school and there are animals around, but the history of bite or anything like that we could not get, and we could not see the ticks as well. We just asked for the history. We know that there are animals, quite a few animals around her residential hostel, and that there are paddy fields around, but we could not get a history of tick bite, or we could not find any ticks on her clothing on admission.
Thanks.
Okay, right, thanks. And here are the images. On top of the T2 axials, there is some degree of cerebral atrophy over there. And the bilateral thalami demonstrate areas of T2 hyperintensity, slightly asymmetrical as we come to along the anterior aspects, but again, the pulvinar thalami demonstrate symmetrical changes of T2 hyperintensities. Brainstem is normal, cerebellum is normal. There are no focal lesions or signal changes. On the diffusion weighted sequences, you can appreciate that the anterior lesions demonstrate restricted diffusion and low signal changes on the corresponding ADC sequences, whereas the pulvinar lesions demonstrate precipitated diffusion. On the flares, again, you can appreciate the changes on the T2 weighted sequences. Again, bilateral thalamic lesions, symmetrical in the pulvinar lesion and slightly asymmetrical in the anterolateral thalamus. Also, if you see the basal ganglia, the left caudate and the anterior putamen is slightly edematous or hyperintense in comparison to the contralateral normal side. SWI sequences could not appreciate any foci of blooming. Spectroscopy was done with foci in the thalamus. There is a lactate peak over there. The choline is slightly elevated, but other than the elevated lactate and the slightly elevated choline peak, the rest of the peaks are normal. So these are the differentials again for the thalamic lesions. Viral infection, as again is pointed out, is primary differentials. Demyelination and MOGA-related antibodies are also differential. Pathology again can present with bilateral thalamic lesions, and again CJD with other viral infections can cause these thalamic lesions. I'll open the case for further discussion.
So I want to add that we got MOG to be negative and J is awaited.
Okay.
Any serology for tick-borne encephalitis in the pipeline?
No, sir, we haven't done serology for that. Only wheel Felix test was done, which was positive, but it's not really reliable. So we have not done any serology for tick-borne encephalitis.
I mean, as Dr. Baltar suggested, it's obviously going to be pertinent to what's endemic in that area. So the differential we would include for the states would be more like West Nile virus or Japanese encephalitis. Sometimes EBV can look like this, but I think it's going to be very specific to your area.
What's the plan, Tanuja?
So we are waiting for the
Japanese.
serology reports, and we are
Okay.
trying to wean her. We're trying to wean her off HFNC.
Okay.
But
The question from Dr. Ramya, IgM scrub typhus, was it done?
that was a scrub typhus. IgM wasn't done.
Okay.
We only wheel Felix test was done, which was 1 in
Okay.
320 positive.
Okay. So primarily infective process dealing with.
Yes, sir.
Okay. All right. If you get the answer on the JE or the scrub
Yes.
typhus, if you're trying to do it, just let us know.
Yes, I will update.
There's a question: role of steroids in this case. Is he on steroids?
So initially we suspected MOG because of bilateral thalamic involvement. We suspected MOGAD. So for that we had given methyl pulses.
Okay. But now you have been off, or is it still on?
5 days of pulse therapy was given, and following which we were able to extubate her also. But her sensorium wise, there is eye opening. She's following objects, but not there is no movement of limbs. Motor component is still not there, but there are no abnormal movements as well.
Is there a case against steroids just as a trial? I mean, it can be helpful perhaps also in non-demyelinating conditions. It's not dangerous to apply it for a short time.
So I did not get you, sir.
I think they've given steroids again for 5 days.
We've given methylpred for 5 days. Yes, sir.
Yeah. Okay. Just let us know if you get anything on the follow-up.
Okay, sir.
Right. Thank you.
Thank you.
Case for Dr. Srikanth there. Okay, I don't think he's there, but I'll go ahead. So this was a 2-year female child with developmental delay, expressive speech delay and spasticity, and presented with neuroregression. No labs, I mean, only the MRI was done. There was no follow-up. I mean, labs and other diagnostic tests are awaited. So initially the child had a CT scan. This is a non-contrast plain CT, and you can appreciate that the white matter is diffusely abnormal. It is a confluent abnormalities are demonstrated in the bilateral cerebral hemispheres. Also, the thalamus demonstrate these hyperdensities almost in a symmetrical pattern. There is some periventricular sparing, but yeah, almost the entire white matter demonstrate these confluent abnormalities. But the cerebellar white matter also has these hypodense lesions, which will be better appreciated on the MR. So here are the MR scans and diffusion and ADC. Again, you can appreciate areas of restricted diffusion, primarily involving the cerebral white matter on both sides and the thalamus, some areas in the caudate nuclei and the central white matter. On the T2s, you can appreciate the extent of the lesions, abnormalities, confluent abnormalities involving the white matter, also the corpus callosum, the caudate nucleus, thalamus, the anterior capsule, the brainstem involving the dorsal area of the brainstem, the cerebellar white matter, and also the pyramidal tracts over there in the medulla. FLAIR images, there is some rarefaction of the abnormal white matter changes on the T2 weighted sequences. Again, hyperintensity is predominantly symmetrical in the central gray matter and the brainstem. The T2 sagittal images demonstrate the middle bed of the corpus callosum is more prominently involved in comparison to the inner and outer segments. The dorsal columns of the upper cervical cord also demonstrate these hyperintense changes. No signal abnormalities on the SWS sequences. Spectroscopy demonstrated a lactate peak. We don't have a diagnosis, but we're thinking of a possibility of the amino acid tRNA disorders, that is ERS2 or the leukoencephalopathy with thalamic and basal ganglia elevated lactate involvement. That was a primary differential. The other differentials we thought of was Kearns-Sayre syndrome, though this child does not have any ophthalmological abnormalities. Subcortical involvement can be seen with thalamic involvement. Other L2-hydroxyglutaric acid and TACO1 are unlikely in this case. So we're thinking of mitochondrial disorders. The primary one was ERS2 and the differential was Kearns-Sayre syndrome. And I'll open the case for further discussion.
I like the differential you provided. You know, I think it'd be nice to see follow-up imaging on this child to see, does the white matter cavitate? Is there a progressive volume loss and necrosis?
I think we're already seeing some area of refraction over there, so I think I would assume that, yeah.
Yeah, probably.
Yeah, yeah.
Would these changes be unusual or normal for current size in a 2-year-old? And is there any evidence of cardiac involvement or retinal involvement?
No, again, there's no evidence.
The age is too early most of the times for concerns. And also, is there any particular handle for amino acid tRNA synthase defects, Nihaal, for us to suspect?
They predominantly involve the brainstem tracts and also the spinal cord. Periventricular predominance is there. So brainstem tracts, I think periventricular abnormalities, and the spinal cord columns, the lateral and dorsal columns are usually seen in the tRNA disorders.
Okay, something like DARS2 and.
Yeah, DARS2 similarly, but they will not have the thalamic involvement. Whereas the ERS2 can have the thalamic involvement. Yeah.
Okay. And typically also spare the subcortical white matter in that.
Yeah. The other fine. Yeah, please go ahead.
Good evening, everyone. This is Dr. Prerna. So I've recently had 2 siblings with very similar pattern of involvement, and both of them are positive for years too, with very high lactate. So I think I'll probably agree with the differential diagnosis for this, because very, very similar pattern with the thalamic involvement and the rest of the white matter involvement.
They're almost from a similar geographic area.
Yes, sir.
Yeah. Okay, we'll get back to you with the genetic diagnosis in the future sessions. Right, thank you. Dr. Vivek?
Yeah, so this is a patient of my colleague who requested me to put on the forum. So I just have the history from him. So he's a 6-year-old boy who had progressive vision loss from 3 years age. So it was more at nighttime and in dimmer light. So more of a peripheral visual loss. And over the next year, he developed a generalized epilepsy, semiology-wise as well as EEG-wise. So generalized discharges. And then in the last year, so initially visual loss, then subsequently epilepsy, and now for few weeks he was unsteady, but not, one won't say unsteady, but maybe due to the vision, or was it really due to any cerebella, and what was not clear. He had a MRI 6 months prior to this visit, which was normal, and ophthalmology showed bilateral optic atrophy. His EEG, last EEG showed only diffuse slowing, while initial EEG had shown generalized discharges. His metabolic workup was done, which showed a normal ammonia and a normal lactate. He came to the hospital because 10 days prior to the visit, he had high fever with thrombocytopenia. And at the time, dengue was positive, NS1 positive, and he developed significant ulcers. So there was acute onset cerebellar involvement during this febrile illness for 10 days prior to admission. And his previous MRI was normal. I don't have the images because, but it was completely normal 6 months before this illness. So these are the MRI films.
Okay, I would like, Nihaal, can I jump in with a clinical question? So what you are describing is more in favor of a retinal involvement. You said it's so at night. So he had a retinopathy, and the bilateral optic atrophy, if this was an optic atrophy, is kind of a secondary. So this is, in terms of differential diagnosis, this is very important. So you have a boy with likely a retinopathy, and now normal MR, and now unsteadiness. And this is suggestive of juvenile NCL. This is high on the list in my mind. And MR is normal initially. And you could look for vacuolated lymphocytes as a screening, and then you need genetic confirmation.
True, because of the visual suggestion of a retinal sort of retinal pathology, because of the history, he was seen by a retina expert, and there was no evidence of any retinitis pigmentosa or any retinal involvement. And this unsteadiness was so that was more visual, and the deterioration was very acute over 10 days after febrile illness, and not like in NCL. And there was no cognitive regression.
This
and
will come.
he doesn't have any erratic myoclonus.
I'm insisting, excuse me. Juvenile NCL starts in the retina, and the brain, in terms of cognitive impairment, comes later, in contrast to late infantile NCL.
Sure.
And still, I believe in history, and your ophthalmologist may not be able to see the retinopathy. You may need an electroretinogram to confirm it.
Yeah, so we don't have ERG. So VEP was done, which was prolonged, which was not very helpful. But ERG, we don't have the facility in Jaipur.
Thanks.
We'll see the MR images and carry out the discussion after. And here are the MR images, diffusion and ADC sequences. Supratemporal brain was normal. And if you come down to the posterior fossa, there is areas of cytotoxic edema or mixed pattern of edema involving the right cerebellar hemisphere more predominantly than the left. Some areas of the left vermis and also the cerebellar hemisphere demonstrate these edematous changes. On ADC sequences, the vermis demonstrates low signal change on ADC, whereas the cerebellar hemispheres have facilitated diffusion over there. FLAIR and T2 weighted sequences again demonstrates the edematous changes in the bilateral cerebellar hemispheres asymmetrically, right more than left. Again, the extent on the coronal images, the more predominant involvement of the right cerebellum in comparison to the left cerebellum, some degree of tonsillar ectopia, and they also narrowing at the foramen of magnum. SWA sequences did not demonstrate any hemorrhage or calcification. Post-contrast study, there are areas of leptomeningeal enhancement in the abnormal areas over there. So based on the presentation, and yeah, the spectroscopy here, we have an elevated choline with a lipid lactate peak. This is, I think, a short TE. The Na and the creatinine is Na is reduced, whereas the creatinine is normal. So I think this was a clinical question, if it is a mitochondrial disorder or acute cerebralitis. The initial differential based on the imaging, on the present imaging, I would think of cerebralitis. They can present with a bilateral involvement or asymmetrical unilateral or bilateral involvement, can have leptomeningeal enhancement over there. This is a paper from Eigen. They have tried to differentiate the immune process from the infective process, and what they found was the isolated posterior fossa involvement with inferior tonsillar ectopia because of the edema is more of an infective etiology, whereas supratentorial brain changes along with the posterior fossa changes can usually is an autoimmune process or an immune related process. MELAS was the question. They usually present with supratentorial involvement, cortical, subcortical involvement, lobar segmental involvement. The posterior fossa is relatively atypical or less common in comparison to the supratentorial involvement. Here are a few cases where it has progressed from the supratentorial changes to the cerebellar abnormalities, but here you can see they are bilateral, almost symmetrical over there. And again, another case report demonstrating changes of MELAS, in case of MELAS with cerebellar involvement. Lerma-Duclos, it is not the age group, and also the changes are not typical of a dysplastic appearance of the cerebellum, but this was just an imaging differential. At this point, I'll open the case for further discussion.
My hypothesis is that this hemicerebralitis is something independent. Yeah. And it would at least not explain the history of the visual loss. If you would argue this is this is part of the same condition, in a mitochondrial condition, I would not expect such an asymmetric finding. So I would tend to wait and see, perhaps repeat the image, this hemicerebralitis will go away, and then you will see what is happening with the brain, and you should consider genetic testing.
Yeah, I agree.
Yeah, I agree. I mean, I think it's unlikely that that we can link the cerebralitis and then the optic nerve disease together. But the mere fact that this child has visual loss for so many years, I don't think that we can simply just describe this as the whole process, everything being cerebralitis.
Dr. Ek, any comments?
No.
Okay.
I put it to get the comments.
Okay. All right. What's the plan, Dr. Ek? Any for the child?
Yeah.
CSF?
So we gave him,
Yes.
No. We won't do CSF.
Okay.
So we gave him steroids, whatever worth it is, because again, with cytotoxic edema, I'm not often sure if it works, but to some degree, because maybe as a pediatric neurologist, now I realize today we are over-reliant on cytotoxic or not cytotoxic to make our mind if steroid will work on. But for me, steroid doesn't work if somebody has predominant cytotoxic, but still give it. So we gave it, it didn't help, and he's gone home with the unsteadiness, with rehabilitation. So I'll see him in 2 weeks. Plan genetics, but family is really poor. So I'm not sure how we'll go about it.
All right, thanks. Yeah, to your next case.
So this is it's just interesting how useful the LS spine contrast MRI can be. So this child came to me with history of fever 10 days prior to the presentation, no diarrhea, just fever and some cough cold, which just improved. And 7 days after that, she was not able to walk on a left leg. And then over the next 24 to 48 hours became non-ambulant. And she was having, appears to be having radiating pain in both the legs. There was no history of any IM injections. And she did start to have later bowel bladder involvement. Her examination showed more of a proximal weakness, which was mostly on the left, but there was some on the right. The straight leg raising test was strongly positive. Sensation was preserved. Her planters were downgoing. Reflexes were absent. So she was fully vaccinated. So I was confused whether I am dealing with a GBS-like phenomena, but it was too asymmetric, or it's a polio-like illness. We did an NCV, which confused me further because she just had left leg motor axonal neuropathy, and the right was normal. Since she was normal, the CSF unfortunately was traumatic, because that would have been very useful, because if there were cells, we were more dealing with the viral infection. If no cells, then obviously more of a GBS-like, but clinically this was more like polio-like illness. But I still gave her IVIG benefit of doubt, and we did then do a LS spine MRI with contrast. It would be nice to discuss about the differential.
Yeah. So these section of images are non-contrast with images. I think only an LS spine was done. So if the findings are on the contrast sequences. So little contrast sequences, we have enhancement of the caudal nerve roots on the axial sequences. The upper sections demonstrate enhancement all in the ventral roots, but as you come down to the lumbosacral or lower lumbar region, we have the dorsal nerve root enhancement also. So it is primarily a caudal nerve root disease with ventral and dorsal involvement. We don't have the other sections of the spinal cord. So again, this is primarily clinical from a review paper, and these are the differentials based on the clinical findings. So I will not go into detail, but here are the differentials for the enhancement pattern of the caudal nerve roots based on the clinical presentation. And yeah, just from the same paper, the differentials of the GBS can have ventral dorsal or both dorsal and ventral nerve root involvement. Other differentials are listed over here. So at least on the imaging, we would term it as a demyelinating polyradiculoneuropathy and base the diagnosis on the clinical presentation and other labs.
So do you think the anterior horn is involved? Anterior horn?
The final part wasn't done. So they're usually in the
anterior horn. Because anterior horn appeared to be involved in the images, significant enhancement.
These are the ventral nerve roots. The anterior horn.
It is not there. The images are not there.
No.
Here they are not there, but they are there on the, because the anterior horn was intensely enhancing bilaterally.
Okay.
Because that helps, you know.
Yeah, that helps.
The cases, because my confusion is the cases we've seen before. So if you have to differentiate between polio-like illness and GBS, is that right? In GBS, anterior horn will not enhance and only the nerve root will, while in a polio-like illness, anterior horn predominantly with some nerve root enhancement.
Yeah, polio anterior horn involvement is common. Yeah, and not in
GBS. It was there in this child. So he has both anterior horn with, because clinically it's polio-like, because in GBS, at least on nerve conduction, you should have bilateral involvement. He just had unilateral. Even the conductions, distal latency, everything was normal on the right side. We have tried for polio virus, but the thing is the child had constipation, so we had to give enemas. So they need a non-enema stool. So that will be followed up with later.
So Vivek, anterior horn cell probably explains the early nerve conduction finding, that which is axona, and it is not demyelinating. And if you are sure that there is anterior horn cell involvement, I'm just wondering whether this location is typical for enterovirus D68, which we had a lot of cases about 5 years back, but I do not know whether it was all Bonus Coda region.
Yeah, I can chime in on that. I don't know. I mean, from that sagittal T2-weighted image, it almost looks like there's some increased signal within the ventral aspect of the cord. It'd be nice to see cross-sectional axial imaging T2-weighted through the cord to see if there's any abnormal signal of the central gray matter or anterior horns. But yeah, that's exactly what we saw with enterovirus D68, which is also the same thing what you see with polio. It's a neurotropic virus.
But anyway, clinically, this is not GBS.
Yeah, clinically not, but imaging wise by the nerve root, it appears to be fun. So that's the confusion, but we give IVIG.
Dr. Just on the imaging, I don't think we can give a diagnosis of GBS on imaging. We usually mention the findings and base it on the clinical, if there's acute paralysis or something like that. I think GBS is a clinical diagnosis rather than imaging diagnosis.
Right.
Good evening, everyone. This is Dr. Juhi. I would like to make a small comment that this case had bladder and bowel involvement. Am I right, sir?
Yeah, later on, just when the child, so not early, later, bladder involvement. But you know, the bladder, maybe her oral intake was not good. Once we admitted her for IFL, she had good urine outputs. I'm not sure bladder, but yes, she had constipation. So bowel involvement was there.
Okay. So we say that we should think of a diagnosis other than GBS if we have a bladder and bowel involvement. And even the NCS did not yield a finding suggestive of GBS. So lately they have described this entity called AFM, acute flaccid myelitis, which is in wherein you get an overlap between GBS and a myelopathy sort of a situation, a transverse myelitis sort of a situation, wherein you can get an anterior horn cell involvement as well as a peripheral nerve root involvement. So to me, especially with you saying that there is anterior horn cell involvement as well, your case seems to fit into acute flaccid myelitis.
Juhi, you gave me the answer. I agree. I haven't heard of it, but I think it all makes sense.
Yeah, and the treatment remains IVIG, but since it's a recently described entity, so I'm not sure whether it is a worldwide accepted terminology, But yes, I'll try to send you the
that was
paper.
very useful because that I think explains. Because I think Nihaal mentioned that there was some spinal cord involvement as well. Some
no, not on these sections, but I thought I didn't have the cervical and dorsal spine.
No, just the lumbosacral. There was some hyperintensity.
Yeah, I mentioned that on the sagittal T2. It looks like there may be some trace
over here
signal. Yeah, it's not.
Which really
not
fits
certain,
in what Jui is saying. So that's very useful. Thank
it's
you.
also the appropriate season, and this occurs every other year, and we're in it right now. So.
All right. Yeah. Thanks. Next case, Dr. A.
So this is more of a clinical dilemma to also convince the family, which haven't been able to. So I promise that I'll put this up in the discussion and try to find an answer to convince them, or maybe I'm wrong. So he's an 8-year-old boy who, for last 6 months, having few minutes of occipital and temporal headaches, which have no relation to straining, exertion. Just few minutes, multiple times a day. Few weeks he won't have it. Few days he will. So very non-specific. But he had an MRI brain done. He didn't have any bowel bladder involvement. No neurological sign. Reflex is normal. Plantar ongoing. No atrophy of arm, hand muscles. No briskness of reflexes. And we did this MRI.
So, Frank, these headaches are not migraine related, or
so few minutes headaches, multiple times a day will be odd for migraine.
Yeah. Just wanted to rule out.
No migraine symptoms.
Got it. Yeah, we have the sagittal sequences, and you can appreciate that there is a craniovertebral junction abnormality. There is narrowing at the craniovertebral junction, CRE1 deformity over there with tonsillar ectopia. On measurement, it was around 21 millimeters below the baseline opistheon line. There is some mild degree of basilar kyphosis. The skull base angle was around 119 degrees. Some thickening of the ligaments over there, posterior to the dens, resulting in narrowing of the craniovertebral junction overall. And there is a focal hyperintensity at the level of the C2 of the spinal cord along the dorsal aspect. This is not thinning. This is just a slice over there. But yeah, there was again no signal. There are some signal changes along the cord. I don't have an axial sequence around the cervical and the thoracic cord, but here you can appreciate that possibly along the central or the anterior aspect, there is some hyperintensity over there in the cord. Again, the axial images demonstrate the compression and the narrowing of the foramen of magnum, the paucity of the CSS spaces in close proximity to the vertebral arteries on both sides. So yeah, this is technically a CRE1 deformity with some craniovertebral junction abnormalities, focal hyperintensity over there in the cervical cord, and a long segment abnormality. Not sure if it's involving the central canal or is it in the gray matter without the axial sections. So the question was, do we operate the child? Is that right, Dr. Vivek?
Yeah, like if we say those headaches are unrelated, maybe somatoform. So maybe we have done a MRI. So if it was not headaches and we did something else, we find this, what do we do?
Yeah, so I looked it up, and this was a consistent paper came out in 2021. And this is what they had described, that if it was an asymptomatic child without syringe, surgery wasn't indicated. Also, children with epilepsy or autism, again, surgery is not indicated, just to relieve the seizure disorder. But in children with symptomatic children, that is with headaches and with other abnormalities related to CRE1 deformity, a bony compression was the treatment of choice, and which had around 80% in agreement. So if you consider the headaches as a symptom and with the spinal cord abnormalities, given the severe degree of tonsillar ectopia, I think probably surgery would be the best outcome or the treatment. But I'm not a neurosurgeon, and I'll probably check with others for their comments.
And there's a hyperintense lesion in the cervical cord, right? Does that also?
Yeah, we didn't have a axial, but is it a central canal which is hyperintense or pre-setting state, or is it a myelopathy? We're not sure of that. But at least this is not a syringe, so there there's something over there in the cervical part.
Which itself might be an indication for surgery.
Yeah. Is it a myelomalacia or early changes? I'm not sure.
I'd be willing to bet if we follow that out that it will become hydromyelia. It's probably, as Nihaal mentioned, precertain state. But yeah, I mean, this to take this even a step further. I mean, this has complex features, which goes by the name of complex Chiari deformity. The skull-based craniocervical anomalies, the fact that the brainstem is elongated, the obex is inferiorly displaced. So not only do I think that surgery is probably indicated, these patients oftentimes require more than one surgery because of all the complex anatomy. And so obviously you want to go to a cautious, prudent neurosurgeon to evaluate this, but this is on the more severe end of the spectrum of what we see for Chiari 1, that is, of course.
Dr. Lokesh, do you want to comment on the possibility of a stroke?
Yeah, I think I was about to do that. So I think it also increases the risk of posterior circulation stroke significantly. These posterior fossa abnormalities and the vertebral arteries do have a lot of wear and tear and possibility of dissection. So I think definitely would require a good neurosurgical evaluation and possibly intervention early.
Is a headache related to coughing, straining, or any position?
That doesn't affect the headaches.
Okay.
I think probably Vivek, definitely a good neurosurgical evaluation and intervention would be very likely in this child.
Yeah.
Okay.
All right. Thank you.
I agree with what you said. I'm not so much concerned about the headache, but I'm concerned about this T2 hyperintensity in the cervical cord. This is kind of cervical myelopathy, and I would hesitate just to leave that alone.
Right. Thanks, Sagan. Next case, Geeta.
Yes. This was a 3-year-old female child who presented to us on about day 3 or day 4 of her illness. Initially outside hospital with fever, cough and cold for 2 days, and then had seizures. These were generalized tonic-clonic seizures. And within a few hours, she developed abnormal respiration and poor respiratory efforts, for which she was intubated and referred to our center. So in our center, almost for 5 days, she was on ventilator, and she had signs of brainstem dysfunction. There was not much a motor response, poor cough reflex, and she was not breathing above the ventilator also. So we initially thought could be any viral encephalitis and all, because she was requiring the ventilatory support and all, we have to go ahead with the tracheostomy after the second MRI. So first MRI was done on the day 3 of illness, and second MRI almost after 5 days.
I think I have only one. Okay. Yeah, sorry. Go ahead.
So here the CSF we have done, it had no cells, and proteins were 20 and sugars were 91, and CSF PCR was also normal, negative.
So this is the day 3 MRI. Again, extensive abnormalities on the diffusion and ADC sequences involving the cortical subcortical regions, but on the ADC you can appreciate that the subcortical and deep white matter demonstrate these low signal changes. The corpus callosum also demonstrate cytotoxic injury. Some degree of the basal ganglia also is abnormal. The anterior and mid portions. Posterior fossa structures do not demonstrate any areas of restricted diffusion, primarily involving the subcortical cortical regions and also some degree of deep white matter, corpus callosum, and the anterior and mid basal ganglia. Corresponding T2 and phase sequences demonstrate the diffuse edematous changes as seen on the diffusion weighted sequences. SWS sequences, we have punctate foci of hemorrhages over there in the perisylvian region and also in the splenium of the corpus callosum, the left parietal region. No blooming or blooming abnormalities in the brainstem of the cerebellum. Sagittal image, again, involvement of the corpus callosum. No herniations, at least at the time of scan. Again, diffuse involvement of the supratemporal brain parenchyma, predominantly in the peripheral regions of the brain. Based on these findings, the imaging diagnosis thought of was ALE-RD. The other differentials over FIRES, which can also present with these diffuse abnormalities. Yeah, so those were our differentials, and I'll open the case for the discussions.
Seizures were there only during the first 2 to 3 days, sir. After that, here we didn't had any seizures. So with such MRI, why like the brainstem dysfunction is not explainable? So how to do a pattern recognition in the encephalitis and all is our question. So with such MRI, how do we go ahead?
No, I think we have presented from our series only patients with single episode of seizures as having ALE-RD type pattern, and also deep brain nuclear involvement. I'm not sure if Dr. Ramesh or Dr. Lokesh for the. I think Dr. Ramesh would have an idea, but
it was the very initial part of the MRI. Actually, in the illness had a very similar pattern. So there was no biphasic illness. Even the first MRI showed this changes. So that's why we were more in favor of a encephalitic process rather than a this one ALE-RD kind of presentation. No flurry of seizures later on and all those worsening of encephalopathy, which generally see with the ALE-RD.
platelet counts per normal. Yeah. Viral PCR was negative. That's for information.
Nasal swabs were done for this child?
No, sir, we haven't done the nasal swabs.
Started off with respiratory, I think sometimes you might get an answer there rather than this one. Okay. Thank you.
Wait. Any comments? Liver function tests. Dr. Sunil.
Liver function tests were also normal.
All right. Yes, Dr. Judy.
Yes. Good evening, everyone. So this child is a 16-month-old male child with no adverse perinatal events, no history of neonatal jaundice, just has a mild language delay, and presented with history of febrile seizures once at 5 months, 8 months, 12 months, and they were always more than one. Otherwise, and which are well controlled. And there is no movement disorder, no regression. The EEG is normal. So MRI was done just as a part of epilepsy, but it shows these subtle basal ganglia lesions.
16 months at mild language delay, complex febrile seizures, and this is the MR. And the T2 on the T2 axis sequences. The question was the medial globus areas of globus pallidus are slightly hyperintense for a 16-month-old child. No malformations, no structural malformations. Brainstem and dentate, no cerebellar white matter abnormalities, no cortical abnormalities were there. On the flare and the diffusion various sequences, again, slight hyperintensities along the globus pallidi, no restricted diffusion, no blooming or mineralization over there, slightly thin corpus callosum, possibly marginal hypoplastic brainstem, but the pontine belly is maintained. Before going into the pathologies, question was, is the globus pallidus hyperintensity is normal for a 16-month-old or not? Probably you see it around 12 months to 12 to 14 months. I've not seen a case. I've compared two cases of similar age group, and the hyperintensity was slightly abnormal for this age. I'm not sure if others would agree. And the different, if that is abnormal, then the differentials are based on the clinical findings for, as Dr. Julia has mentioned, possibility of SSDH. A spectroscopy wasn't done for the GMP deficiencies, which can present with these abnormalities. And I'll open the case for discussion. There's a comment upon SCN1 related seizures. Dr. Julie, if you want to take that up.
So the child does have febrile seizures starting in the first year of life, but the rest of the things, afebrile seizures are the kind of seizures, the developmental delay are yet not there. So are these GP hyperintensities significant at this age, and should I be planning a genetic evaluation?
My personal opinion, which
I would,
I'm not excited about this finding.
Yeah.
I wonder whether you should just wait and see. I mean, this child is well. This is kind of an incidental finding. I mean, this is not the SSADH or creatine deficiency. I think you can afford to wait and see.
I think several people in the chat box have commented about SCN1. I agree. Typically, we don't get developmental delay until the age of 2 years, and you can have both febrile as well as febrile seizures. So I would definitely do an SCN1 mutation analysis.
I mean, I think that you've provided a very healthy differential diagnosis for globus pallidus hyperintensity, but I do think the scan is abnormal. I don't think that is a normal finding for age.
At least on the flares, they look more conspicuous than PET2s, but yeah. Dr. G, probably wait for some time and probably get a follow-up if it is still persistent, or if they're progressing, then check for genetic disorders.
Nihaal, can I just ask you a quick question?
Yeah.
And maybe I'm over-interpreting these scans, but on that third image on the top row, does the temporal lobes, like posteriorly, do they look too bright, or is that just some sort of artifact? I mean, I'm not familiar with this institution scanners, and so maybe that's something that we're just cutting through in a funny way, but it's for whatever reason.
Sorry, go ahead.
It just looks a little bright to me there, and that's all. Just questioning that.
Yeah. Actually, it was not done at the institution where I work, but I thought of the same. But again, I looked at the temporal lobes over there, and possibly the occipital lobes. They're all slightly smudgy over there. So
maybe
if it's
it's
artifactual or
then.
real, probably it's an artifact. Yeah.
Gotcha.
All right, Dr. Jui, anything to add, or?
Yeah, okay, no, that was very helpful. I'll follow up and I'll keep these things in mind. Thank you.
Yeah, all right, thanks.
Yeah, so this child had 2 episodes. The first episode was last year, and she had a febrile illness followed by encephalopathy and extrapyramidal movements, and COVID was positive, and all the MISC markers were elevated. So she was actually treated as MISC with steroids. And so I have seen the child on both occasions only after the acute episode has subsided. That is in follow-up. So that time, looking at the imaging pattern, I had sent an autoimmune panel and genetic testing, and the genetic testing revealed a RANBP2 mutation, which was autosomal dominant heterozygous, and which was actually reported in another case of ANEC, which was an ClinVar database. It is likely pathogenic, and somewhere it is given as US, and the lab had reported as US. And then nevertheless, over the next 1 year, the child improved significantly, although still was ambulating with support. Then this year, September, she again had a fever for I think 3 days. On day 3, she developed encephalopathy, and because this time there was already a prior history, on day 1 itself, the steroids were given. And this time, the illness was much shorter, and she responded very well. The first time she went on ventilator and all, but this time she remained quite okay. So now I want to discuss the imaging with respect to ANEC, especially the posterior limb of internal capsule findings in the second scan. And secondly, wanted to know the group's opinion on the kind of immunosuppression, because monthly IVIG and 2 monthly IVIG was one thing, but that is maybe it is not affordable, and I could not find a strong literature on that. And looking at the pathogenesis, which involves the cytokine storm, I want to ask if cyclophosphamide could be a good choice.
May I ask you how impaired the child is?
So in terms of the modified Rankin scale, after initial episode, she was bedridden, so let's say 5. And then she started ambulating with support after first episode. Now again, the best she can do is sit up on her own from the bed, but cannot stand. So she's quite debilitated.
All right, we'll have a look at the images and get back to the discussion. So this is the first scan in 2021, and you have near-symmetrical areas of abnormality in the perinsular region, the bilateral thalami demonstrating restricted diffusion, the medial temporal lobes, the mammillary bodies, the brainstem. Again, typical changes of acute necrotizing encephalitis, corresponding T2 changes in the perinsular region and the thalamus over there. Contrast enhancement, no significant enhancement. Follow-up imaging, the edema is slightly progressed involving the central white matter. Brainstem changes also there, almost involving the complete midbrain. The corresponding diffusion, again, you have ischemic necrotic changes in the bilateral thalami, the brainstem, with corresponding low signal changes on the ADC sequences. So the question of the radiological appearance of ANEC, it can involve the white matter and can also involve it can be more confluently involving the white matter, periventricular and deep white matter, also the central white matter. So that does not go against an ANEC, which is typically known to cause the central gray matter involvement, but white matter involvement can be seen. This was the question. This was the genetic diagnosis of an uncertain significance, but we can be sure that the imaging phenotypes matches an ANEC. This was again a paper in 2020 where they had done a literature review for RA and BP2 mutation related cases of ANEC. Again, there are no differentiating features to differentiate a genetic versus a non-genetic cause, and they are typical involvement of the temporal lobes, the thalami, brainstem, cerebellum, and less commonly the basal ganglia. Even the question of immunomodulation and treatment, there are different papers which have postulated the guidelines for treatment of ANEC. Again, as Dr. Julia has mentioned, there was no evidence to support immune-mediated disease or immunomodulatory therapy. But this was the first case from Italy which had antiviral and immunoglobulins given, and the child is still on low-dose steroid treatment. So I'll not go into detail for the treatment. I'll leave that to the clinicians. But these are few literature references where they have tried to postulate the management for ANEC-related cases.
Well, my understanding is that even if you treat, the outcome is not that great.
Yeah.
And in the case which I personally managed, the course was similar, that the child was bedridden for several weeks and then started to ambulate with the support, and she used to smile. After the second episode, family decided to withdraw the care.
Julie, the second gene was Aicardi-Gouttiere. So there is a subgroup of Aicardi-Gouttiere who presents with very similar acute illness later in life and with similar MRI changes. Like and a cytokine storm, people now think in Aicardi-Gouttiere as well, where particular genes cause perinatal, the other genes cause postnatal and childhood onset cytokine storm. You know, it's some sort of a vasculopathy, vasculitis, Aicardi-Gouttiere, congenitally induced vasculitis. So because IFI-H1 can cause similar changes, but I might be wrong. Did you check? Like this is something one could check as well, because Aicardi-Gouttiere is not the one we always think of often, as we know. It's not the one which can always present with hepatosplenomegaly, thrombocytopenia, first few months onset dystonic tremor. It can present at this age also.
I may have missed the point, but were parents examined genetically for RANBP2?
No, sir.
It can be de novo.
Right. The parents were not examined, so they were not affording to undertake the testing.
Because both genes should be ideally examined in the parents. Ideally.
Right. Right. So I wanted to know the group's opinion that if this is some sort of a immune mediated, a gene which is predisposing the child to immune mediated damage, then which immunomodulation, a long-term immunomodulation, would you recommend?
Because it again brings to the same discussion, those LRADs and everything where it's more the initial cytokine storm. Should we use IL-1 or IL-6 inhibitors? And in a para-infectious process, which was like that patient with basal ganglia involvement, should we use steroid and IVIGs, rituximab? And even cyclophosphamide is more of a T cell and some B cell modulator, but I might be wrong. It's not a IL-1, IL-6 modulator, is it? Like I haven't checked. Cyclo is more T and B cell. No, not poor man's. I think it's a very good drug. I shouldn't say poor. So it's a T and B cell, more T than B, but definitely I think not an interleukin inhibitor. Is that right, Juhi? I haven't checked it.
Right. I think so, sir.
So something like because this is logical out, you are saying that something suddenly happens in all these patients, either it's ALRED or ANE, which is more like within the first few days of illness, it's more of a cytokine storm which damages. And in these patients, genetic predisposition to those cytokine storms. So one should give something which inhibits that rather than IVIG, which won't work, or rituximab, which won't work here. Or maybe even cyclophosphamide won't work, but maybe steroid works for everything, even for interleukins. So one could keep her on a small dose, alternate day steroid for few years, like maybe that's the option. But first we need to be sure that is it RAN-BP2 or Icardi-Gutierrez. I'm sure it is RAN-BP2, but I think both should be confirmed.
Dr. Juhi, I just want to make a small comment. This is Dr. Prerna. I have a 7-year-old girl who presented to me with 4th episode of acute encephalopathy following febrile illness with this symmetrical concentric pattern in the bilateral thalami. So even for her, the RAN-BP2 was variant of unknown significance, autosomal dominant heterozygous. But during the acute episode, we used IV tocilizumab, and that seemed to work quite well for her. So we could wean her off the ventilator, and although she is currently on tracheostomy, her recovery is much quicker than what I have seen in previous children, like who've not been treated with tocilizumab.
Right. That was very helpful, ma'am. But the only thing in this case was that I have seen her in follow-up when she got discharged, but certainly tocilizumab in acute stage would be of help.
So now you have to look for the inhibitors, which will be more like, long-term. That's what you're asking, aren't you? Which will prevent further events.
Right. So this
the problem is they're also
yeah.
costly, because a patient who cannot even get, parental testing done, unless does the government pay for it? Like, is it something which is payable?
For some immunomodulation, it is there, it is available.
Because these are tocilizumab is not that costly, but for long term, if you have to give some form of an inhibitor as a prophylaxis, the ones which you are given IV, so that will have a cost.
Right.
All right. Thanks, Dr. Juhi. Thanks, everyone. I have just one follow-up case from Dr. Rashmi, which was discussed in June. Dr. Rashmi, do you want to quickly summarize?
Yes. We discussed this boy in June, actually. He's a 15-year-old boy who had presented with fever for 3 days, headache for 3 days, and altered sensorium. So initially, we started ceftriaxone, vancomycin, acyclovir, and all of that. And we also took CSF for autoantibody and MOG as well, and a PAMI, which was negative. But he was strongly positive for MOG. So then we treated him with IVIG and methylpred, but then his first MRI showed brainstem encephalitis. So he was ventilated for almost 2 weeks. And the time we presented last time, we had a failed extubation. So we then gave him 1 dose of rituximab. Following that, and a week down the line with MMF and rituximab, we were able to extubate him. And I'm pleased to let you know that now, we've 3 months down the line, he is absolutely fine. He's attending school and he's doing his exams. And we found it really, that, from brainstem encephalitis, he's made a completely full recovery with no neurological deficit. So he's currently weaning his steroids down, and he's still on MMF, which I think I'm going to keep it until a few more months.
So this is the initial scans. Again, some hyperintensities around the peridolinic cortex, bilateral thalami, brainstem, and the cerebellar white matter. On the other sequences, you can appreciate the involvement of the pons and the medulla. Post contrast, there was no enhancement. Optic nerve, there was no optic. There was some degree of optic neuritis, if I'm not mistaken. Dr. Rashmi, was a VEP done?
No, there was no optic neuritis.
Okay.
Yeah.
So spinal cord, there were no lesions, and this is the follow-up imaging 3 months later. There is some degree of volume loss in comparison to the primary study, but the lesions have completely resolved. Yeah. So on imaging, there's complete resolution with some degree of volume loss, and I think clinically also the child has completely recovered. Is that right, Dr. Rashmi?
Yes, clinically he's completely recovered. He has no neurological deficit. He's attending normal school. He's even doing these entrance exam coaching and all of that. So he's made a full recovery from this, complete recovery from this. So he initially gave him 3 months of oral steroids. Now I'm weaning down the steroids over the next 3 months. And MMF, we have continued right from the day we started when we came to know it was MOG positive. I did one more MOG antibody just out for academic interest, and it was still positive. I think I've heard that there is no relationship between MOG being positive and the clinical features, but my plan was to wean him off the steroids completely, and provided it doesn't relapse, then after that, take him off the MMF.
So Dr. Rashmi, so yes, anti-MOG positivity. So we always thought that if NMD is positive, MOG is positive, there is no relation to long-term prognosis. It is incorrect actually. Now MOG, it has now been proven. Children who become MOG negative earlier, they tend to go into remission much faster. So one should do 6 monthly MOG.
Okay.
Yeah.
Okay. We've done it 3 months. Just when we did this MRI, we also did a MOG. So what was strongly positive is now just positive. But he's continuing on the MMF.
So MOG should be done 6 monthly. It's got a very, so there are 2 recent papers, really good papers. So MOG who have become negative, those patients tend not to relapse over years.
Oh, okay, fine. Okay. Could you share that with me, Dr. Vivek?
I attended a neuroimmunology course, so they mentioned that, but I'll find it. It should be somewhere.
Yeah.
Okay, if there are no further comments, that's our last case. Thank you all for your active participation, and thanks again, Aigen, David. Thanks for joining us as our panelists. We'll see you again on the 28th of October, same time. Kindly submit your cases by 25th to either of these emails.
Thank you very much, everybody.
Thank you, Nihaal.
Thank you.
Thank you.
Thank you.